thank you first of all for the invitation, and I wish I could attend it in person. The next best thing is giving it remotely, so hopefully this will be a valuable one. So when well, unlike the stated scope of this talk, I will not be presenting any case studies. Instead, I'll be presenting novel methodologies for two common types of public and global health trial designs in a Bayesian adaptive setting. So before we talk about the specific types, let me see. I'll be discussing, the particular features or characteristics of global and public health trials. So those trials tend to be on the larger side, often, tens of thousands of patients, especially if we're talking about, say, vaccine trials or cluster randomized trials, the type I will be presenting today. They tend to be fairly long. But I suppose that's not always the case. For example, they are no longer than the typical oncological trial that measures overall survival that often includes a follow-up time of 5 years. Here we might be looking at birth outcomes, for example, in which case we'll be monitoring the mother and the child for a year or two. Oftentimes, those will be multi-center trials, which means that there are logistical challenges, especially if those trials are run in low and middle income countries. And importantly, those trials tend to be funded by either nonprofits or taxpayer money, and that means that we have to be careful about our spend. In terms of the impact of those trials, typically, those trials are conducted at the population level and do not focus on a small segment of the population like many pharmaceutical trials. So the impact is potentially very high. And for all of these reasons, I think it is worth doing all we can in order to save on time and resources. And that's exactly what we are here to do. So the first type of design that so before that, let me just go quickly over the same concept that Harun just described. Bayesian adaptive trial designs are simulation guided, exactly the same way that Harun presented. We typically run a large number of simulations to evaluate their operating characteristics. This is also a blessing because if we can simulate it, we can, consider the type of designs that we wouldn't normally, because we are not now bound to the all the type of mathematics that allows us to measure those operating characteristics. We can simulate everything on a computer and see how we fare. A lot of the time, we'll be considering multi-arm, multi-stage type of designs in which we can call the shots or make decisions throughout. And those are the adaptations. That's the adaptive component. For example, we may be testing a bunch of active treatments versus a common control, in which case decision will take place based on what we call the posterior probability of efficacy. That's the posterior probability that the treatment is effective, namely better than the control, given the data that has been observed. If that number is exceedingly high, we might stop recruiting patients to that arm and announce it effective and apply early, for example, for emergency use approval. If that number is very low, we might stop early and say this particular treatment is a lost cause, no need to recruit any more patients. And we call that futility, but it's not futility per se. It just means that in the context of this trial, we won't get a chance to recruit sufficiently many patients to establish efficacy. And so that's once in a while we test a bunch of active treatments versus a common control. but we may also test a bunch of active treatments against each other and try to pinpoint the best one among them, in which case we'll be using the posterior probability of superiority, that is the posterior probability, given the data, that each of the particular treatments is better than all the others. As I mentioned, the potential benefits are early or emergency use approval that will be submitted earlier. We may also recruit fewer patients to futile arms. And instead, if we have already found an effective treatment, we may give them an effective treatment instead, for example. If we are lucky, we may also not use up the full quota of enrolled patients that we planned, and that will also represent saving in resources. So the first type of design that I'm going to present will be a multi-arm, multi-stage vaccine trial. And multi-arm, multi-stage vaccine trials, so vaccine trials as a whole, are typically event-driven designs. What do I mean by event-driven? Instead of treating a fixed number of patients and at the end counting the number of cases observed in each one of those groups, I may run the trial in a different manner. Here, what we look at is how much the vaccine slows down the infection process. So what I can do is decide on a number of infections that will be observed before I unblind the data and measure the efficacy of the various vaccines. For example, I can say, okay, once 50 infections overall across all arms have been observed, let's stop temporarily for an interim readout, unblind the data, and see how many of those infections occurred in each of the arms. And the basic assumptions here for those who are on the quantitative side is that each of those counts follows the Poisson process. And the vaccine effect that everyone talks about since 2020 is basically the relative rate reduction of each of those live vaccines relative to the placebo arm. So I already covered how the trial is run in terms of the unblinding. The big point here is that we can show that some transformation of the vaccine effect can be shown to follow. It's not a multinomial distribution, it's actually a Dirichlet distribution. This is my typo here. And that means that we are able to use a Dirichlet prior and derive a Dirichlet posterior that represents a big saving in computations. Let me be a bit more specific here. So what we do here, the VEs are the vaccine effects of the different groups. I'm not going to delve into the details. I'll just mention the big points. I can show that some transformation of those vaccine effects actually represents the probabilities of multinomial cells. The multinomial distribution here, that represents the distribution of the different cell counts or the infection numbers. The multinomial distribution has a conjugate Dirichlet prior, and that means that the posterior distribution of those parameters will also be a Dirichlet one. The Dirichlet distribution is just a multivariate generalization of the beta distribution. So it's a bit like the beta binomial distribution extended to any number of groups. Once we have that those Dirichlet posteriors, we can back transform those to obtain or to infer on the vaccine effect. So the big message here, we can do everything in a very computationally efficient way. And everything will depend on the number of cases observed and the allocation ratio, because what we did here was extending the type of design that was used by Pfizer BioNTech in their COVID trial, or COVID vaccine, not just to any number of arms, but to also any kind of allocation ratio between the different vaccine groups and the control group. The reason we did that was that once you go beyond two groups, just placebo versus vaccine, it becomes beneficial to randomize more patients to the placebo group. So we don't want to restrict ourselves anymore to a one-to-one randomization. On top of that, we also propose the principled way for choosing a prior distribution for those strange parameters, the transformed ones. We derived closed form for all inferential quantities, namely the mean vaccine effect, the median vaccine effect, the quantiles, and most importantly, the posterior probability of efficacy. This will have crucial implications on our computation time. And as things stand now, we can easily run 100,000 simulations in around 1 minute on a standard PC, specifically on my laptop here, a Lenovo laptop with 20 logical cores. So the reason why this is a point I keep stressing is that in order to evaluate the design's operating characteristics, we need to run a large number of simulations, and the rule of thumb at the FDA is 100,000, because that's when the Monte Carlo error becomes really small, and we can take those estimates as is, as if those are the actual probabilities. And we'll get back to that. So here is an example of a multi-stage, multi-arm vaccine trial. What I'm going to do here, I'm going to test 3 vaccines against a placebo. And because I'm testing 3 vaccines versus a common control, I'm going to change the allocation ratio such that I randomize around 72% more patients to the placebo group compared to the three vaccine groups. This kind of allocation is called the net allocation, and its benefit is that the average uncertainty is minimized for the different vaccine effects. Think about it, because this same control group serves every one of the vaccine groups, it now assumes a special importance. It's no longer just another arm. What we will do is that I'm going to test or to simulate vaccines with vaccine effects of 50%, 37.5%, and 25% against this common control, common placebo, with obviously a vaccine effect of 0. And I'm going to conduct my interim analysis whenever, on average, among those arms that have not yet been dropped, 10.5 events or infections have been observed. So, for example, when I start a trial with 4 arms, I'm going to wait until 42 infections have been observed to conduct an interim analysis. If I dropped 1, I'm left with 3. I'll be doing it after 32 because I'll round it up, and so on. An arm will get stopped for either early efficacy or early futility. For efficacy, I will stop it whenever the posterior probability of efficacy exceeds 99.025%, and then I will obviously apply for emergency use approval. This number, just like Haolun mentioned earlier, was chosen in order to, under the null scenario, control the type 1 error rate for each of those arms at the 2.5% level. For early futility, I'm going to use a progressive schema of the thresholds. At the first analysis, I'll stop an arm if it goes below 25% efficacy or probability of efficacy. Then I increase it to 50% and to 75%. The reason being that as the trial progresses, I will have fewer chances to turn things around. There will be fewer patients remaining. So the chances of an arm that shows little promise all of a sudden becoming effective decreases over time. Now, let's see what happens. So first of all, I'll just talk briefly about choosing a prior. So the priors were chosen to guarantee that at the outset or a priori, each of those vaccines will have a 50% probability of efficacy. And basically, I'm keeping things neutral. You can also see that this translates into a median vaccine effect of 0. And then I just I need to select a bunch of hyperparameters. I play with one of them, the hyperparameter pertaining to the vaccine arm, and then each of the vaccine arms, and I match a hyperparameter for the control arm or the placebo arm that will guarantee this prior probability of efficacy of 50%. This gives me a bunch of prior candidates, as you can see in the figure, and I go with the one that feels right for me. For example, in this case, what I'm going to do is I'm going to choose the one at the top of the table, or the blue density plot, because it, for example, contains also very high vaccine effects. I don't want to rule out the possibility of, say, 95% vaccine effect a priori. So I'm going with the most vague one of the lot. And this is what, for example, a sample trial looks like. I just, I programmed the simulation, and I run one trial at a time. And this is what a sample trial looks like, a random trial. In this case, for example, I'm monitoring the posterior probability of efficacy. You can see the dashed lines, those represent the decision boundaries. In this case, after 2 interim analyses, the third arm was already shown to be futile. It wasn't shown to be futile. We just decided that according to the boundaries that we set, it stood a very small chance of eventually becoming effective or showing to be effective. So we terminate it at that point after 2 analyses, and we keep going with the 2 other vaccine ones, and obviously the control one. After the third analysis, the first arm was found to be effective. It crossed the upper boundary for efficacy, and we stopped recruiting patients for that arm. We no longer monitor patients that receive that treatment or that vaccine. The second arm in yellow made it all the way to the end of the trial without any clear decision. It bordered on efficacy, but didn't quite make the cut. In terms of the numbers observed, we can now see the summary of this particular random trial. We can see on the rightmost column the eventual vaccine effect estimates, posterior medians and 95% Bayesian credible interval. The numbers again used to simulate this data were 50% for arm number 1, 37.5% for arm number 2, and 25% for arm number 3. All of those are contained in the resultant credible intervals. But we can obviously not establish any conclusion on a single trial. Rather, I would like to establish conclusions on 100,000 simulated trials, which is the next thing I'm going to do. So after 100,000 simulations, I calculated the operating characteristics. I just collected statistics. What I did was I ran the trial as I showed it a moment earlier, 100,000 times. And in addition, I ran the trial under no effect for any of the arms 100,000 times. And that's the top row in the table. What we can see is that when all arms have no effect, essentially when all vaccines have no effect, we have a power of 2.5%. That's the type 1 error rate. We can also see that we stand almost 80% probability of stopping the trial earlier than the eventual 4th analysis. under the null scenario. And then, for example, under the alternative scenario for each one of those arms, we can see, for example, that the arm with 50% efficacy or a vaccine effect of 50% also stands a very good chance of stopping early. And that chance obviously decreases as the efficacy level or the vaccine effect decreases. So just a discussion point, we stand a very good chance of stopping early, but it doesn't mean that we necessarily save on resources. To save on resources, we'll also need the infection process to be so much quicker than the enrollment process, such that when we stop an arm, we still have people in the pipeline who haven't received the vaccine. In this case, the most likely outcome is everyone receiving the vaccine, but we will at least save on time to emergency use approval application, just as we saw with the famous Pfizer trial when the application was made early based on the first interim analysis. The second type of design I'll be discussing is the cluster randomized trial. So let me give you a brief introduction of cluster randomized trials for those who are not familiar. Cluster randomized trials, or CRTs as we call them, are trials that are conducted at the cluster level. What does that mean? It means that the randomization unit is no longer the individual. It is, for example, a village. If we try to prevent malaria, we could put sugar baits outside the village, and then essentially everyone living in that village is treated. So the randomization unit here is no longer the patient, it is the village. Some villages will have sugar baits laid outside them, and those will be the treated villages, so the treated clusters, and some villages won't, and those will become the control clusters. When we operate that way, all of a sudden we have not just the single variance component in our model. It's not just the individual to individual variability. It is also the cluster to cluster variability. For example, some villages are at a higher altitude than others, so they are less prone to malaria infection, right? So the basic event rate also changes, not just at the individual level, but also at the cluster level, right? And the challenge of these trials is to disentangle the cluster to cluster variability from the subject to subject variability. And so when that happens, when we have these two variance components, we call that variance inflation. And the amount at which the variance increases is called the variance inflation factor. And the variance inflation factor is governed by two factors. The larger the clusters, the larger the variance inflation, and the larger the intra-cluster correlation coefficient, the larger the variance inflation. What is the intra-cluster correlation coefficient? It is the correlation between subjects within the same clusters. Same cluster. For example, if I get infected with malaria, what does that imply on other people living at the same village as me? Does it also imply that they have an increased risk of getting infected in malaria? And as I mentioned in the example I gave, for example, altitude could be perceived as a very strong determinant of malaria infection. So people living at the lower altitude in the tropics, say, that village could be thought of as having a very large intra-cluster correlation coefficient because they all stand together a very high risk of getting infected. So the reason I'm mentioning this is that that's part of the work we've done. We managed to relate the ICC to the model that we came up with. What we did here was we proposed the Poisson gamma mixture model. I'll be more specific in a moment, to model CRTs with binary endpoints. And we showed that some transformation of the mean event rate has a conjugate beta prior, and as a result, a beta posterior, in the same way that we did it for the vaccine trials. We no longer work with the original scale, we work with some transformed scale, and then retransform to perform all the inferences in our scale of interest. In this case, the mean event rate. We established the mathematical relation between the gamma random effect parameters and the intra-cluster correlation coefficient. So that allows me to simulate trials under different ICC scenarios. And we propose the principled way for choosing prior distributions, just like we did for the vaccine trials. Furthermore, there is some nuisance parameter that I have to specify numbers for, or values for. That the nuisance parameter is the shape parameter of the gamma distribution. I'll show it in a moment. What we did was we derived again an empirical based algorithm, or a principled way for specifying those values. And now, well, it's no longer the 1 minute that we managed to run everything at for the vaccine trials, but 10 minutes for a 100,000 large simulation is still pretty good on a standard PC without using Amazon Web Services or anything. So the model that we're using here is the Poisson gamma mixture. That means that we model the number of infections, for example, the number of malaria infections, if you will, in every village to follow a Poisson distribution. We know that the Poisson is a good approximation for a binomial distribution with a large sample and a small infection probability. So that seems to fit the bill. And to capture the cluster-to-cluster variability, we model the event rates to follow a gamma distribution of a very specific form. The reason I'm doing that is that if you have a Poisson gamma mixture, then the marginal distribution, the marginal infection counts, if you will, distribution can be shown to follow a negative binomial distribution. This negative binomial distribution has the benefit of having a conjugate beta prior. Again, this is a negative binomial distribution not in the original scale. It's a negative binomial distribution at some transformed scale of the mean event rates of which we care. So this is how we select priors for that beta binomial distribution. Or that, the beta distribution, in fact, or the beta priors for the beta binomial distribution. What I do here is, for example, I fix the mean event rate at a value for all arms. I want to assume that all arms have a mean event rate of 10% within the follow-up duration of the trial. So I expect at the end of the trial, 10% of the participants to eventually get infected if I do nothing. And what I did here, for example, I simulated, or I didn't simulate actually, I calculated everything assuming an intra-cluster correlation coefficient. This is the raw parameter in the table of either 0.15 or 0.2. That's a pretty standard ICC in the global health setting. And the corresponding shape parameter for my gamma random effect, for basically the cluster-to-cluster variability that matches this ICC and this mean event rate, happens to be 0.74 for the 0.15 ICC and 0.56 for the 0.2 ICC. Then what I do is I fix the first hyperparameter at some integer, in this case 2, 4, 8, and 16, just to see the differences between the different priors. And all of these other conditions constrain the other parameter to match a certain value. So in this case, for example, at the top one, we get a hyperparameter of b equals 1.3. I then inspect visually all of my priors and see what they look like and calculate some summaries of those. And in this case, again, I chose the most vague one, the one that has a equals 2 and b equals 1.3. Graphically, that's what it looks like to the left. That's the blue density plot. So that's just a technicality that I must go through, unfortunately. Once I have these priors, I can now simulate a trial just like I did before. Strangely, I chose the exact same event rates as Haolun in the previous talk of 10%, 7.5%, and 5%. So what I'm going to do in this case, I'm not going to test everyone against a common control. Rather, I'm going to test all three treatments and try to identify the best one among them. I allow myself a maximum of 550 clusters of an average cluster size of 50 each. So think of those as 550 villages of an average population of 50. Throughout, if any arm has a posterior probability of superiority that goes below 1.2%, I stop it for futility and I continue with the remaining ones. Likewise, at any point, if the posterior probability of superiority exceeds 98.8%, then we basically terminate, we end the trial and we declare a winner. The data was simulated under the assumption that the intra-cluster correlation coefficient was 0.15. And here is a sample trial. In this one random trial, what we could see is that the first arm with an event rate of 10% stopped after 2 interim readouts. The remaining arms, arm 2 and arm 3, continued all the way to the third and final analysis, in which the third arm with an event rate of 5% was found to be superior to the second arm with a mean event rate of 7.5%. So again, you cannot base any conclusion on a single random trial. Therefore, I conduct 100,000 of them. But before that, I promised earlier that there was some technicality that I needed to go through, namely specifying values for those shape parameters. I don't want to delve too much into that. That's you can find it in the manuscript for those who wish to read it. But all I'm saying is that we are maximizing the log marginal likelihood. Basically, that's the likelihood once we average over the prior values. We maximize each component, each arm, the component pertaining to each arm individually, and we come up with plug-in estimates for those nuisance parameters. You can see in the plot how I fared relative to the true one. So the blue dashed lines represent the estimated shape parameters, and the yellow ones represent the true ones. So I think we do it generally very well, actually. And once I supply value for those nuisance parameters, I can do all of my inferences. Just a moment. What I want to show, yes. So for this one particular trial, those were the results. If you look to the right, you can see again the estimates and the credible intervals for each one of those event rates. So 8.9% for the arm that had a true mean event rate of 10, that is well within that credible interval. Then 7.9% for the 7.5%, and 5.4% for the 5% arm. All sit nicely within their credible intervals. And this is what happens once I run this same simulation 100,000 times. Now, this is a more complicated scenario because it's very difficult to define what constitutes a null hypothesis here. Is the null hypothesis just like in the ANOVA case, in the typical ANOVA case, everyone is equal? or is the null hypothesis, there is no clear-cut winner among these three. If it is the first one, then you can look at the second line in this table and see that they have a false positive rate of 2%. You can think of that as your type 1 error rate. If it's the other type of a null hypothesis, meaning that there is no clear-cut winner, then even a scenario where we have two very effective treatments that are equal between them, it's also part of the null hypothesis. In this case, I have a false positive rate of 9.7%. So we have to be clear about what forms a null hypothesis here, right? Because I'm doing something that is very ambitious. I don't just rule out equality among all these arms. I also follow through and point out which of them is the best one. And if there is no best one, as in the third line here, then any treatment that I identify as the best is a false positive. But either way, I don't think that's bad. I still have 80.6% power, if you will, of identifying the correct best treatment. And the average number of clusters that I use in this case is 412, as opposed to 528 clusters that would be required only to compare arm 1 and arm 2. In this case, if I was using the standard requesting test. Another point to look at is the proportion of patients that receive the worst treatment, in this case, the first one. You can see, for example, that under the top scenario, the alternative scenario, if you will, only 21% of the patients received the worst scenario. The worst treatment. Whereas if we conducted just a 1-to-1-to-1 standard frequencies trial, we would end up giving 1/3 of the patients this worst treatment. So this is kind of an ethical consideration of conducting an adaptive trial. I now wish to conclude everything and leave you some time for questions. So as I hope I convinced you in the very first slide, global health trials could use every bit of help, because they are long, expensive, logistically challenging, and we essentially all pay for them. So there is no commercial interest behind them. So adaptive trial is one way of creating that efficiency. The algorithms I proposed here are all MCMC free, and that's crucial because we need them to be fast, because we need to run a large number of simulations, and I do it 100,000 of those in minutes, just because I spare the need to run any MCMC. In fact, as far as I can tell, this Bayesian adaptive or this Bayesian cluster randomized trial that I propose is the only one I'm aware of that requires no MCMC. Response adaptive randomization, for those of you who know what it is, it means that we can change the allocation ratios midway through the trial according to the observed response. So treatments that show more promise along the way will all of a sudden have a larger number of patients randomized to them. So in this case, I can see how it could work. First of all, because for the vaccine trials, it is crucial that we keep the allocation ratios between all the vaccine groups and the treatment group, and the placebo group constant throughout the trial. And for the cluster randomized trial, we have a balancing issue. Because the randomization unit is the cluster and not the individual, those trials are more prone to imbalances as far as the baseline characteristics of the patients. So we don't really want to create this skew in the way that we allocate the patients or the clusters to the different arms. As far as time to outcomes, so what I wanted to say by this, I'm saying consider time to outcome and enrollment rate. Could your trial benefit from adaptations? What I'm saying by that is that it's very appealing to now recommend adaptive trials for everything. But the fact of the matter is that if you have a trial that has a very slow outcome to record, such as, for example, overall survival that takes a full 5 years, and at the same time, the recruitment process is very slow, if the recruitment process is actually very quick, then by the time that you get the chance to conduct your first interim analysis, everyone has already been enrolled, randomized, and received the treatment. So we cannot actually adapt anything. So use adaptive designs whenever it makes sense. Possible extensions to this work. So for the vaccine effects, I present here a work that assumes that the vaccine effect remains constant over time, but we know that that's not the case a lot of the time. We know that the vaccine effect appears to wane over time. So that's a natural extension that we should consider. As far as the cluster randomized trials, there is a pretty popular extension of those called the stepped wedge design, in which all clusters initially do not receive the trial, do not receive treatment, and as we go along over time, more and more clusters gradually start receiving the treatment. So that's a trial in which you can think of it as each cluster becomes its own control because they both receive and do not receive the treatment. So I sense that with some work we could extend our work on cluster randomized trial to also incorporate those. And as a final word, anyone who wishes to read the preprint is welcome. I also provided the conference organizers with an HTML tutorial where you can run the code and recover the results, and also access the code and the manuscript and read everything if that's of any interest to you. So thank you very much, and here are some references.